our public forum. And I'm Dr. John Tooker. I'm the chairman of the board of the National eHealth Collaborative. And as always, I want to bring to everybody's attention that we have a conflict of interest policy, and that if any members of the board note a conflict during the course of the meeting, please do raise that conflict with the other members of the board and with me. I also want to introduce Brian Heckert. Brian is our new interim executive director of the National eHealth Collaborative, and we're very pleased and privileged to have Brian here with NEHC and with us today. I also want to welcome the members of the public who are here in person and any members of the public that are coming in through a variety of sources, including our webinar today. As you may recall, in keeping with our commitment to full stakeholder participation, we have provided a variety of ways for our stakeholders to join us today. Anybody can join us over the phone, and our presentation slides are available on our website, which is www.nationalehealth.org, and via webinar. And we are broadcasting a live video of this meeting over Ustream TV. For those of you able to join us here in person, printed copies of the presentation slides are available on the registration table if you would like to follow along or take notes. We have also tried to make it easy for those of you online to participate in today's meeting, as it is for everyone who has joined us in person today. As we did last month, we welcome your questions via the webinar or email to info@nationalehealth.org. That is info@nationalehealth.org. And our staff is monitoring a Twitter hashtag #NEHC. It takes longer to introduce how we're going to do the meeting than it does to do the meeting. Now, we are very privileged this morning to have a panel discussion from one of our key stakeholder groups. As you may know, if you followed NEHC from its inception, we have had really outstanding panels at our meetings that represent the views of our stakeholders with respect to health information technology. As we continue our work to understand and address the barriers that are keeping us from full HIT adoption implementation, we have chosen to focus our attention today on a special part of our healthcare community, our healthcare safety net providers. We are privileged to have Michael Lardiere, a board member of NEHC and a consumer representative on the NEHC board, who comes to us from the National Association of Community Health Centers to moderate our panel discussion today. He has brought together a great panel representing a number of the many services that make up our safety net to talk with us about the unique challenges they face in implementing health information technology. Before Mike introduces our panel, we want to emphasize that the purpose of the panel is to inform our board as well as the members of the public about the unique aspects of this particular stakeholder community, our safety net providers now. And we will be managing the time with our presenters so that there will be time for questions. And at the end of our time this morning at 11:50, we will also take public comments now. So without any further delay, I'd like to introduce Mike Lardiere, who will introduce our outstanding panel and lead the discussion. Mike?
Thank you, John, and good morning, everybody, and thank you for this opportunity to provide this presentation, which focuses, the title of the presentation is Safety Net Providers Striving for Interoperability, Barriers to Adoption. So what we'll address here are some of the issues that remain in the safety net provider community providing services to underserved populations. The panel discussion today is made up of a number of speakers. We'll start off after myself. I'll provide a little brief presentation of the community health center environment. Nicole Lamoureaux, who's the Executive Director for the National Association of Free Clinics, will then provide a presentation on that perspective. Yvonne Claudio, who's the CQI Coordinator for Ambulatory Health Services at the Philadelphia Department of Public Health, will then present. Eggleston, who is the Director of Public Policy for the National Council for Community Behavioral Health, will give perspective on behavioral health issues. And then Ruth Perot will wrap it up. And Ruth is the co-founder and Executive Director of Summit Health Institute for Research and Education. So we'll start off here, and let's see if we can get the technology to work. Right? Okay. Briefly about federally qualified health centers. They started back in 1964, and back in 1996 there was an act that brought community health centers, homeless, migrant workers, and public housing centers together under one act. And they're located in underserved communities. They have to be designated as a medically underserved area. They're governed, what makes community health centers different than many other organizations is they're governed by the community. So it's 51% controlled board need to be recipients of service at the health center. So it's very community controlled. And they provide primary care services, coordinate services. It's comprehensive treatment, provide behavioral health, dental, all under one roof. So they're one-stop shopping for consumers. This map will show you where they're located. Right now, the data that you're seeing is from 2007. We estimate the number of patients that are seen now at 20 million versus 16 million in 2007, and that number is growing with the number of uninsured as that grows. And there are over 1,200 individual clinics, community health centers across the country with over 7,000 sites. And this gives you a little idea of the type of patients we serve. So 1 in 20 individuals across the country are served in community health centers. 1 in 12 African Americans, 1 in 9 Hispanic Latinos, 1 in 8 uninsured are served in community health centers, and 1 in 7 individuals living below 200% of the poverty level. And also 1 in 4 homeless people in the United States are also served in community health centers. And this just gives you a little graphic of how that breaks down. We'll look at those numbers. And I guess I wanted to reiterate those numbers so you'll see them a couple of times. Also, there are 468,000 who have other public insurance over and above Medicaid. It's interesting to look at the diagnoses that are treated in health centers. Hypertension is first, diabetes is second. But then 3, 4, and 5 are could be considered are behavioral health disorders, actually, depression and other mood disorders, other mental health disorders, and then anxiety disorders. And then number 6 is heart disease. And that's going to be an important thing to look at, to remember as we move forward and talk about the behavioral health issues as well. So we did a survey of community health centers in 2008. We had 37% response rate, and I think some of the information that we'll provide briefly here will give you an idea of some of the gaps that are still present in the health center world. Health centers, FQHCs, were eligible and are eligible for money under ARA and also from money from HRSA, but just having the money doesn't get you to where you need to be. So this just shows that the study we did pretty closely mirrors the population of our health centers in rural versus urban areas. 53% of all health centers are in rural areas, and the 47% are in urban areas. We looked at the functions used by CHCs, and these were the criteria that were used before meaningful use, in quote, criteria came out, and for a fully functional EHR. And if you can see that there isn't any bar across the graphic there where health centers were using electronic health records that 100% of them met the mark on any one. And out of the respondents that responded to the survey, when we dropped out, we dropped out public health reporting, and then there were 2 health centers that actually met the mark for 100% of fully functional EHR. So they still have work to do, even though they have EHRs implemented. They self-reported as being all electronic versus part electronic. And it was interesting that there a higher percentage of health centers in rural areas identified themselves as being all electronic versus urban areas. And when we looked a little deeper at that, what we saw is it seemed to correlate with the number of providers. In rural areas, the average number of providers in the health centers was around 10, where in urban areas is around 20. So to get 10 practitioners to work within EHR and change your systems around, it's probably a little easier than when you have 20 and double or 3 times as many patients. So that seemed to correlate with the higher all electronic in a rural area. Health center controlled networks, so we looked at those health centers that belong to a health center controlled network. Health center controlled networks are groups of 3 or more health centers who come together. One of the health centers then takes over the core functions of one of the core components of operations. Usually it's HIT, and so they'll host the servers and they'll host the EHR for a number of other health centers. They'll provide first-level support. They also do better with purchasing and those type of things. So, and you can see that those folks who are those health centers that were belong to an HCCN, we call them Health Center Control Networks, were more likely to be all electronic versus part paper, part electronic. So that extra support is really very helpful. We think that the health center controlled networks should be sought after as a partner, any regional health information exchange, because they're already doing this activity hands-on now, so they'd be an excellent partner for any of the regional health information exchanges. We then looked at both on the behavioral health and the oral health side of if their systems, if they provided behavioral health and oral health in the health center, and they had electronic systems. We asked if their systems were communicating. And actually only about 20% of those systems talk to each other. So they're not sharing e-prescribing functions, they're not sharing many of the other functions, they're not pulling out data and merging that data together. So there are gaps there in terms of integrating systems. And this just shows that they're actually less than 20% of the health centers only have one site. More than 80% of all health centers have more than one site. Of the folks, health centers that responded, only 20% of those health centers that responded actually share data electronically currently. And when they ask who we share data with, most of it is with hospitals and then also with clinical labs. The reason the clinical labs is so high is because health centers have been involved in the health disparities collaboratives for a number of years. And part of that is diabetes collaboratives is the major one that all health centers participate in. And they've made arrangements to have that data shared from the labs to go directly into their disease registries, which all health centers actually use. And the type of data exchanged, again, laboratory is the biggest one, and then patient demographics, and then disease management is other data that's shared.